So my charge this morning is to introduce you to nephrotic syndrome, and I'm going to start out, fairly basic and just kind of give you an overview to hopefully set you up for the talks that follow. The first very important concept to get is that the diagnosis is not nephrotic syndrome. We use nephrotic syndrome all the time like it's a diagnosis, but it's not really a diagnosis. It's a constellation of findings that fit together and lead you to a group of diagnoses. But nephrotic syndrome, are the signs and symptoms of the disease, but not the cause of the disease, The diagnosis are diseases like minimal change disease or focal segmental glomerulosclerosis that you're going to be talking about quite a bit today, or membranous nephropathy. Those are the diagnoses, the diseases that cause the nephrotic syndrome. Nephrotic syndrome, that constellation of signs and symptoms, consists of heavy proteinuria, means lots of protein in the urine, hypoproteinemia, low hypoprotein, emia is in the blood, so low level of protein in the blood, edema, which is generalized swelling, and not usually just swelling in the arms and the face and such, but often fluid in the abdominal cavity and in the pleural space, the space around the lungs, not in the lungs themselves, but around the lungs. And high blood cholesterol levels, which seem how to tag into the defect of handling replacing the proteins in the liver, and I'm not going to go into that at all except to tell you that it's a part of it. Just for a review for most of you, this is your wonderful kidney, which is such an important organ, and in every pump of your heart, the kidneys get 20% of the blood flow as it comes out. So this part, the white part on the outside, is the cortex, which is where all the little filters are. And then the urine follows through some tubules that empty into the collecting system here. This is the blood supply into the kidney. And then the urine goes down the ureter. So the important part for you to know is that this outer part, the cortex, has about almost 1 million filters in each kidney. And then each little filter connects to a tubule that dumps into the collecting system right here with these calyces, it's called, all these little points into the kidney, and then the urine flows down the ureter. This is a schematic, which I think makes it a little bit easier to tell what's going on of each filter. So the filter has a blood supply here, the blood vessels, and this is sort of an cross-section of the blood vessel. These are red blood cells here. And then this is the filtration surface right here. And in here are what the lining cells of the blood vessel called the endothelial cells, and then these are the famous podocytes over here. And then this is Bowman's space. So this is each filtering unit. And the urine goes out here down the tubule, and the tubule fine-tunes the urine, regulates the total amount of fluid, sodium, potassium, etc. in the urine. The filters do an start filtration, and what comes out in the final urine is only about 1% of the volume of what starts down all the cumulative tubules here. So the tubules do a lot of fine-tuning. That fine-tuning is very important. But when we're talking about nephrotic syndrome, we're talking about the problem is here in the filters, and particularly in this filtering surface here. So that's what you're going to be hearing a lot about today. This is the same schematic when you've got protein in the urine. and for some reason, which I'm not going to go into, but interestingly, these, if you noticed on the last one, where the podocytes are, see how these are all spiky? And then if I go here, this is all smooth and fused. So this is fusion of the foot processes. Those spiky things are the foot processes of the podocytes. And it is the having a lot of protein in the urine that fuses these foot processes. So when we're talking about biopsy changes and you hear fusion of the foot processes, that's a non-specific finding that just goes along with having a lot of protein in the urine. And this shows you on an electron micrograph. So this is incredibly magnified. These are the blood cells. This is the blood space, and here is the basement membrane, which is the filtering surface. And then here are these fused foot processes here. And you can see that the schematic is ever so much smoother, but you get the idea here, too, that that's what's happening. So this is real life of the schematic, a little bit more magnified. So, so then what happens in the body with nephrotic syndrome? This is a conceptual systematic that I'm going to go through with you that you have to realize is oversimplified, and that we know there are a lot more offshoots to this, and it doesn't, it's not quite so sweet and simple as this, but if you get this concept, it helps you to understand where the swelling comes from and how those pieces of nephrotic syndrome go together. Why does losing a lot of protein make you swollen? You know, did you think about that? How do those go together? That's not, you know, immediately obvious to sometimes even my medical students. So what starts out is protein in the urine, protein and then urea means in the urine, which then decreases, the arrow here of decreased blood protein level, which then leads to a decrease in the oncotic pressure in the blood vessels. And oncotic pressure is a property of the small proteins like albumin. Albumin is the protein that is lost in the greatest number. It's a small protein, and it's lost in great amounts in nephrotic syndrome. And albumin has a property called oncotic pressure. And the easiest explanation that I have for oncotic pressure is that it's like a sponge effect in the blood vessels. The blood vessels actually, those blood vessel cells, that lining endothelial cell that I showed you, they are not tight junctions there between each cell. And fluid can leak on out into the tissues. So this sponge effect that you get when you have a level of albumin in the blood, when the blood protein levels are where, and particularly the blood albumin levels where it should be, creates a sponge effect, and that keeps the fluid in the blood vessels. So if you don't have that sponge effect, then the fluid doesn't stay put. So when you don't have normal oncotic pressure, the water flows out of the blood vessels, which then reduces blood volume. The kidneys then sense this reduction in blood volume, and they say, oh my gosh, we should make less urine because there's not enough volume in the blood, so let's concentrate the urine and cut the urine volume down, and then your urine gets real dark and concentrated, and you know, you don't pee very often. Your urine output goes down, so you're hanging on to water in the kidneys. They're not putting out, you know, what you drink, they're hanging on to because they think that they should. But what's happening into this fluid is it's flowing out into the tissues and making edema instead of, so you drink, it goes into swelling. And it doesn't, you don't stay in that usual fluid balance that we should stay in when we drink. Then the other thing that happens is when your blood volume goes low, there's a connection between the kidneys and the brain, and you get thirsty. So that low blood volume you'll get thirsty. There's a feedback system between it, that goes together, thirst and the kidneys conserving fluid and reducing urine output, are tied. And so you get thirsty, and so you start drinking a lot. And then what happens to that, what you drink, it doesn't go back here and increase your urine output. Your increased fluid intake then, because of this whole process, is going to add to your swelling. So when patients say to me, oh my God, my child was not looking bad a day ago, and then overnight he just blew up. And I believe that, because I think what happened was that child got to the point of not having enough protein in the blood, got very thirsty, wasn't making much urine, and bang, drank a lot overnight, and indeed, blew up and got very swollen. So, so the diseases that are going to do this, a schematic that we're going to talk about today, are mainly going to be minimal change disease, focal segmental glomerulosclerosis, and then there's a mesangial proliferation kind of variant of these two that is not always separated out, but sometimes you'll see it separated out, and people will say that they have mesangial proliferative disease. There are also a lot of secondary situations where you have nephrotic syndrome, where there's another kidney disease that causes nephrotic syndrome, or there's a systemic disease like lupus that affects the kidneys and causes nephrotic syndrome. Terms, just to make them more clear to you, nephrotic reveals to nephrotic syndrome and this whole process of protein loss and edema. Nephritic means a more inflammatory renal disease, and generally with protein in the urine too, but not to the degree of nephrosis. So we are seeing that the disease that we're concentrating on now that is, so much more common is this disease, focal segmental glomerulosclerosis. There were two studies done together that came out in the same time in about '99 that first showed this, and then there have been a lot since then that focal segmental sclerosis is getting more and more common, and the simple minimal change disease less common, and those children who have minimal change disease are having more and more difficult disease with more relapse, more steroid dependence, and more need often to go on to other medications. Just to review for you so you know, the kind of diseases that are secondary to and have secondary nephrotic syndrome that are pure renal diseases are this list here. And it's not an all-inclusive list. And then there are diseases that are secondary to systemic diseases that have kidney disease as part of them. And that's a list. I'm not going to go through those. And sometimes you can have nephrotic syndrome as part of an infection-related disease. Now, this is your typical child with who presents to me like the pediatric nephrologist with nephrotic syndrome. You see what Lou Antosh was talking about, these swollen eyes. The people often, the pediatrician who sees maybe 2 new cases of nephrotic syndrome in a career, it's, in my book, it's a common disease, but in the general population, the kind of incidence of nephrotic syndrome in childhood is a couple cases per 100,000 children. So it's not a super common disease.